Good afternoon, everyone. We are going to get started. Thank you for finding your way to this building. I know for many of us, it's the first time we've been in this building, so thank you for making the extra effort. So we have the pleasure of being enlightened today by an amazing, dynamic speaker and researcher who is in the space of urban planning and public health, and many more layers to his research than that, but let me introduce you to a little bit of his background. So Dr. Andy Hong is an assistant professor in the Department of City and Metropolitan Planning at the University of Utah. He is a director of the Healthy Aging and Resilient Places Lab, whose mission is to create healthier and more resilient places for all people across the lifespan. His research examines the interplay between the built environment and human health, with a particular focus on the social and environmental determinants of health. His goal is to work with local communities and stakeholders to develop an equitable and sustainable place-based approach to healthy aging and resilient places. Dr. Hong previously held positions at the University of Oxford, the George Institute of Global Health for Global Health, the University of British Columbia, and the Korea Transport Institute.
All right. Thank you so much for such a wonderful introduction. It's an honor to be here as part of the Hyde lecture series. And when I was arriving here, the weather was perfect, but the next day becomes the day and night, so I don't know what to make of it, but I guess I brought all these cold weather from Utah. Before I start the talk, I would like to break the ice by asking some questions. So I'm going to ask you a very, very tough question. So how many of you would like to live to be 100 or a year or more? Okay. How about living well and healthy to be 100 years or more? Well, that was a tough question, right? So we all want to live healthy and well until we die, right? So healthy aging is something that we all want. In this talk today, I'm going to talk about how we can create a place for healthy aging. And the answer may not be that simple. So I give you a warning. And it may actually be a little more counterintuitive. So this is the agenda for today's talk. I'm going to give you a little background about the connection between the built environment and health, and then move on to discussing some of the built environment factors that may actually deter our health. And shifting gears a little bit to think about health through the pandemic, and then conclude my talk by talking about resilient places for healthy aging. So a little bit of background first. So this is a map of life expectancy at birth from CDC. And it gives you a general picture of the entire US by the states. And you can see some pattern over there, right? And you might be wondering how Nebraska is doing compared to other states. And it's doing fairly well at 79.6 years life expectancy. So that's good. Let's compare that with Mississippi, which has the lowest life expectancy in the US at 74.9. So let's do the quick math. So what's the difference? So it's the difference of 4.7 years. And that's a huge difference. So what's going on here? Right? Of course, the picture is a lot more nuanced. It's not about state by state, but it's more about the community by community, and they have all these differences. But you see these patterns, right? So you see these southern states relatively have lower life expectancy than other states. So what's going on? And actually, it turns out that life expectancy, I guess health more in general, is affected by a lot of factors in our life. And we're just looking at the tip of the iceberg. So if you look at these underlying factors, we can categorize them into these 4 groups. First, with healthcare, genetics, environmental factors, and individual behaviors. I would like you to take a note that healthcare and the genetic factors are responsible for only 40% of our health, whereas the environmental factors and individual factors are responsible for almost 60%. So this is a dirty little secret in the medical industry that we're putting billions of dollars in genetics and healthcare, and yet we're not conquering all this disease because of this issue. And it's a good news for us as a built environment profession, as an urban planner, architects, interior designer, urban designer. We have a huge role to play, maybe more so than doctors and healthcare professionals. And this is the sentence that really summarizes what I was talking about earlier. Your zip code matters more than your genetic code. And this is not coming from me. This is coming from a doctor named Tony Eaton from California Endowment, who is a vocal advocate of the social determinants of health. And what this tells us is that the built environment plays a huge role for our health. Your zip code matters more than your genetic code. That's true. So let's talk about what are some of these built environment factors that go against healthy aging. Let's find out what they are. And I'm going to give you 3 cases in point. So the first case in point is sprawl development. We know it when we see it, and it's everywhere. So take a look at this neighborhood. It's got a beautiful house, parking lot, huge backyards. Maybe it's an American dream come true, right? But there's a problem. This homogeneous neighborhood, this focusing on single residential use, turns out that it's not really good for your health. So this is a recent study that looked at 30,000 people across the United States, and they measured their participants' cognitive functioning. And they link those measures with all the neighborhood amenities surrounding. For example, they measure the density of businesses, availability of parks, recreational centers, and whatnot. And what they found was that there was a positive correlation between all these neighborhood amenities and their brain health. So this study tells us that all these neighborhood amenities promote more walking, more social interactions, which in turn actually help with our brain health. Another problem with sprawl development is that when you get older and can no longer drive because of physical limitations, aging in place means that you're stuck without options. And that's a really big problem for people living in rural America. You're stuck without options. So I wrote this article for New York Times last year addressing this very problem in rural America. And I worked with the team at New York Times to conduct several interviews with people around the country to understand their challenges in terms of their mobility and transportation. And we created this beautiful piece with illustrations and voice recordings of older adults, of their lived experiences. So I highly recommend you to check this out, harp.utah.edu, and you can go to the story. So let's take an example from this recording, this example from Janice, 77-year-old, living in Gig Harbor, Washington. And she has a really big problem with transportation that relates to her health and her husband's health. Let's hear it.
We don't have a car. There's no public transportation here, at least none that stops anywhere accessible to us. We would either have to walk half a mile down a very busy highway with no sidewalk. The other option is taking taxis, which would cost about $40 a day round trip. We need an absolutely reliable thing because my husband has dialysis 3 times a week. At the heart of the problem is the fact that we don't have proper public transportation here in this particular part of Gig Harbor or Pierce County. This isn't an inconvenience. It's a matter of life and death for my husband.
So in these, for some people, transportation is a real barrier. And the statistics tells us that 1 in 5 people in America are missing their doctor's appointment because they have no transportation to get there. And this number is actually higher for older adults. So let's move on to the second case in point, which is related to sprawl development, but focusing on car-oriented neighborhoods. To highlight my points, I would like to compare these two neighborhoods, one with the walkable place, the other more car-oriented place. And, they seem perfectly okay. Maybe the walkable place seems more interesting than the car-oriented place, but car-oriented place has its own appeal, right? But the problem starts to emerge when we do a deep autopsy of these two neighborhoods. Suppose that you're living in the center of the neighborhood and your home is in that center. And let's draw a 15-minute walking range from your home. In the walkable neighborhood, you can walk to many destinations within 15 minutes. But in the car-oriented place, maybe there's no place that we can walk to. You may need to even drive 15 to 30 minutes to get to your first destination. And this is a really big problem for people living in rural and suburban neighborhoods. So we're living in a car-dependent society. We're driving everywhere. We're driving to school. We're driving to work. We're driving our kids to school. And this is a really big problem. And this is a funny picture that I show to my audience. So basically, we even drive to a gym to the point where we drive there and take an escalator. Isn't it wonderful, right? So essentially, this is what needs to happen in our daily living. So maybe we sit on our desk for a few hours, but then our everyday lifestyle needs to focus on constant activities, constant movement. And we have to do a lot more of these lifestyle physical activity. But what we are doing is the complete opposite. We're upside down. So we're spending very little time exercising, occasionally maybe going to the gym. But every day, we're becoming completely sedentary. And this is a really big problem. So, in a way, we effectively engineered physical activity out of our lives for the sake of convenience. And that's not really good for our health. Research after research, we are finding out that car driving is closely linked to obesity and other chronic problems for our health. And it's not just a correlational study. A recent study looking at 200,000 people from UK Biobank, following people over time, they were finding out that car driving is detrimental to our health. So research after study, research after research, this is what we're finding out. And I've done one of those studies looking at the built environment and chronic diseases. So we did this in Canada, and maybe you've heard about this term called walk score, or walkability index. So we built this walkability score using these 4 measures: residential density, commercial density, also known as FAR, floor area ratio, and we use land use mix and intersection density to construct this walkability measure. And we visualize these walkability score in the city of Vancouver to find out which part of the town is more walkable versus less walkable. And what's unique about this study is that we use this data and link it to personal medical records and medical billing records. So we have about 200,000 people mapping all these built environment measures with their personal health records. So we have a very granular data. And the results was quite striking. And we had a doctor on board, and he was nodding their head, this can't be possible. What we found was that compared to people living in car-dependent neighborhoods, people living in most walkable neighborhoods was 42% less likely to have to be obese. And the same goes for diabetes. People living in car-dependent neighborhoods, compared to them, people living in most walkable neighborhoods were 39% less likely to be diabetic. And because we have this medical billing records, we were able to calculate this into a dollar term. And that really resonates with a lot of our policymakers. So compared to people living in the less walkable place, people in most walkable place, there were 23% less costs associated with diabetes, and 31% less costs associated with heart disease. We pulled out this from medical records, medical billing records, and we was able to do this because Canada has a central health insurance system, so we can pull this massive information. But what this tells us is that if done right, built environment does not only help with our health, but it can also help with lowering cost down the road. My last case in point is because of this car-dependent society that we live in, there's no place to walk or use wheelchairs. And that's a big problem. So let's take a look at this photo. This photo shows the gross marginalization of pedestrians in our urban space. So if we dig out all this space occupied by cars, we are left with very tiny little space reserved for pedestrians. And this is the hard reality that we live in today, and I get goosebumps every time I look at this photo. And a recent research actually tried to quantify this lack of pedestrian space in our urban space. So they quantify the share of sidewalk in our urban space in 10 different cities around the world and rank them by order. And guess what? All these American cities were ranked lowest compared to their European counterparts. And if you look at the top and the bottom, which is Denver and Paris, you start to see the stark difference in their built environment. So in the case of Denver, the roads are usually wider, and in some parts of the city, and mostly in most of the parts of the city, cars are dominating, as you can see from the red colors over there. Whereas in Paris, the roads are a lot narrower, and in some parts of the city, pedestrians are more dominant than cars. Of course, you will say that Paris is an older city. It's got all these pedestrian-friendly features. Right. But what this really tells us is that the impact of built environment can last for decades, if not centuries. And we have to start right from the beginning. Otherwise, we'll end up inheriting all these nightmares, if you will, for urban planners. So aside from the lack of pedestrian space in our cities, many American cities are actually struggling to keep up with their sidewalks. So there are a lot of broken sidewalks in our cities. Maybe you have experienced some of that while walking in your neighborhoods. It's really dangerous, especially for older adults. And we're not really paying enough attention to these. So the dangerous sidewalks and fall injuries, there is a really recent research that looks at and compares the prevalence of pedestrian falls in outside environment versus pedestrians' motor vehicle collisions. We tend to focus on these pedestrian crash a lot. We see these all the time in the news. But we don't see all these pedestrian fall incidents. And it turns out that the volume of pedestrian falls is twice that of pedestrian motor vehicle collision. And when it comes to older adults, it's 6 times more. So this is a really big problem in our cities. And people are paying attention to these pedestrian crash, that increased level of pedestrian crash in our cities. But what's more increasing is the prevalence of falls in our cities, especially for older adults. So let's actually hear this story from John Ligon, 75 years old, living in Atlanta, having to deal with these problems in his sidewalk.
In Atlanta, the sidewalks are very, very inconsistent. I'm legally blind, and I would say I've probably got like 20% vision. Can't see depth, so I just have to be so careful because all it takes is a piece of concrete that's up a couple of inches for me to catch my foot and fall down. I mean, it's all it takes, so I have to just look down all the time. I've just got to be on guard all the time.
So as you can see with the Jan's story, the older adults are quite vulnerable to these type of broken sidewalks. And that's probably the reason why older people don't really go out as often. So let's switch gears a little bit and think about health from the perspective of resilience. And we all know the pandemic gave us a really good chance to rethink our health. And surprisingly, the older adults were the hardest hit during the pandemic. But ironically, they were the most resilient people. They knew how to cope with these challenges. So we set out to find out what are some of these characteristics among older adults that help them become more resilient during the pandemic. So we did a photo voice study asking older people to take photographs of meaningful places that will help them overcome some of these challenges, and ask them to provide the descriptions based on their own experience. So we did interviews, we did focus groups, of course all through remote platforms like Zoom, but we collected all this information during the pandemic. And we did a thorough analysis based on this qualitative information, combining photos and descriptions. And we found that there were 5 themes that come out from these qualitative efforts. And we grouped them into 3 different categories. First was about identity and belonging. So older people were eager to stay close to people who are close to them, so their friends and families, and they were not afraid to use new technologies like Skype and Zoom to stay close to one another. And this was something new because we thought that older people have difficulties with technologies. They may not be willing to learn new technologies. But it was the opposite. They were really, really focusing on staying close to other people. And technology was not a barrier for them, for some of them. Another theme, the larger theme that comes out from this exercise was they focus on activities. So just like everyone else, older adults were eager to go out and get some fresh air. And they were open to new ideas. They showed the remarkable skills in terms of learning new skills, new hobbies. Some people picked up skills to play piano, guitar, learn how to dance. So they used this moment to actually learn new things. And lastly, they prioritized their personal values. So it was not just about their religious beliefs. And of course, you see that people living in Utah have certain religious beliefs, so that maybe the older adults were more focused on that. But it was more about finding meanings in their lives, finding purpose in their lives. And by doing so, it really helped them overcome the hard realities of COVID. For example, their friends passing away because of COVID. And we also looked at some of the challenges in aging in place from the perspective of aging service providers. And it shows a little bit of a different picture. So based on the focus group, we found out that the aging service providers were really thinking about technology and has its own two-edged swords. So for many people, they say, it expanded options for many older adults. But people who don't have technology, it was a big problem for them. They also mentioned problems with social isolation and mental health. So seniors were receiving regular care and regular services. All these services were cut off. So they were really struggling to keep up with their mental health during the pandemic. And lastly, they had to deal with this emergency preparedness and also with home safetiness because some older adults didn't even have a refrigerator in their house because they were reliant on these meal delivery services from the service providers. So the first thing that they did, the aging service providers, they actually bought a refrigerator, small refrigerators, to all the older adults and older clients that they're serving. So with all this, I'm going to talk about how we can create resilient places for healthy aging. And this is much of work in progress. So I'd be happy to discuss further after the talk, but I would like to share some of my ideas for making resilient places. So resilience, by its definition, is the ability to bounce back from adversity. And that's a traditional definition, and we all know it, right? And in the traditional health and medical field, they talk about these 3 domains of resilience. So first, starting with the cognitive functioning, and psychosocial functioning and the physical functioning. And they talk about exposome, which is basically our environment. But the traditional health and medical framework focuses on this internal capacity of their patients. But there are other definitions and frameworks of resilience. So for example, this is the urban resilience framework that's widely used in urban management. And they talk about these 4 different stages of resilience. First, starting with increasing awareness, providing coping mechanism, increasing adaptive capacity, and enable transformative change. So based on these different characteristics of resilience, maybe the easy way to start is being aware, finding vulnerabilities in our environment. All the way up to a transformative stage where you're having a step change in terms of creating and making a leap forward in our ability to become more resilient. So I borrowed this urban resilience framework to develop my own definition of resilient places. That is, a place that enables individuals to identify and withstand challenges while helping them to adapt and transform their environment for health and well-being. So it's a lot, so I'm going to break it down for you. So let's start with identifying. So identifying vulnerabilities and increase awareness. So that's the first step to make our place resilient. The second step is to develop and provide all these coping mechanisms so that we can withstand shocks and stresses in our environment. Third step is to support adaptation. So, making people resilient doesn't stop them from being, going back to the status quo, but we can help people to be more adaptive, increase their adaptive capacity in time of hardships. And lastly, probably the most hardest and which takes the longest time to achieve is the transformative stage where we enable people to transform themselves. So it's not just about increasing ability to bounce back, but it's helping people to adapt and helping people to transform themselves. So let me give you a few examples how we can achieve these through resilience placemaking. The first about identifying vulnerabilities. So this is an example from the study that I'm doing with multiple universities in Korea. And one of the objectives of our study is to assess fall risk environment among older adults in older communities in South Korea. And we're using this mixed method to combine interviews, focus groups, and also quantitative data to unpack some of these fall risk factors in their environment. And this is an example of doing an interview with an older person. She's talking about all her experience of falls and inside their house, outside of their house, and we get a lot of insights just by talking to them. We also used this fall risk checklist that allows us to identify fall risky environment in these 6 domains, ranging from surrounding environment, entrance, home environment, stairs, bathrooms, kitchen. And it turns out that the bathroom was the most vulnerable place for most people. And this is a really interesting photo from one of our participants. And she was using this wobbly step to get in and out of her house. And we weren't we wouldn't have been able to find out about this until we actually do an interview with that person. Because we thought it was just a temporary fixture, but it was actually, she was using this as a main entrance to her house. And we saw a lot of cases like this. So in addition to this qualitative research, we are doing some quantitative work using GIS analysis to identify fall risk, and also using street view images with deep learning techniques to identify some of these fall risks in the outdoor environment. So we're creating this fall risk map, and the benefit of using this quantitative data is that it enables us to not only just look at household by household, but it allows us to unpack some of these fall risk environment at the neighborhood scale, at the regional scale, and probably at the national scale. So we're kind of being ambitious, but we're trying to combine this qualitative data to provide insights, but also using this quantitative data to allow us to scale our research. This is another example showing how we can create resilient places through developing coping mechanisms. I talked about this earlier during the lunch, but this is a study called Nature RX. So in this study, we are running a 4-week program, nature-based intervention program, combining mindfulness training and nature walking. And we are working together with University of Utah Healthcare and the Red Butte Garden to prescribe nature instead of giving people drugs. So the initial results of our study looks quite promising. So many of our participants showed a significant reduction in their depression score before and after the participation of the program. And our qualitative research piece really helped us understand the efficacy of doing this nature-based program from a therapeutic perspective. Some people actually certainly prefer this program over medication because there was no side effects. And we were quite surprised to find out that the program also increased people's social connection. This was something that was not expected, but after this program, some people actually maintained their contacts. So they use this program as a way to break away from their social isolation. Of course, we found some challenges. There were challenges in terms of transportation barriers and also logistic barriers. But I think this is a really good example of showing how we can use the nature-based interventions to develop coping mechanisms. Another example is called Capable Study from Johns Hopkins. This is a good example showing how we can adapt our environment to become more resilient. So when they're doing this routine nursing visits to their patients, they found out that a lot of their problems is not only related to their health and medical issues, but related to their environmental issues. So they start pairing up with handyman to fix some of these issues in their house. So they're running this national study in 35 locations across the country to do a home retrofit programs as part of the nursing visits. So I think this is a really good example of showing or using existing programs like nursing visits and combine that with environmental interventions. And their earlier findings suggest that some of these environmental interventions, the home retrofit programs, is more effective than giving them medication. Last but not least, this is a good example of creating resilient places through transformation. So this is a study called cobblestone mat walking study. And the researchers ran this 3-month cobblestone walking program among older adults, which led to a significant increase in their physical functions. As you can see, there are a lot of the domains in their physical functions improve over the 3-month period. And this is a bit counterintuitive because normally we would want to remove all these barriers in people's environment. Instead of doing that, researchers provide small barriers so that we can train older people to become more resilient in various conditions, in various built environment. And I think this is a really good example showing that we can use urban design, we can use environmental design as a way to create a more transformative change in our environment. So in this talk, I talked about how we can create resilient places through increasing awareness, providing coping mechanisms, and increasing their adaptive capacity and transformation. I think there could be other approaches. But the key takeaway message from my talk is that we need to rethink our approach to health from the perspective of resilience. And resilience is key to our health. So, thank you.
What I found after I retired, I decided to start walking. I increased my walk from about 1,000 steps a day to almost 5,000 steps a day. And my health increased significantly to a point where I am now healthier than I was when I retired.
Wow, amazing.
That was 5 years ago. Did your studies at all do much in the way of walking?
Oh yeah, definitely, yeah. You heard about the blue zones, maybe. So the 4 components of blue zone is about physical activity, walking. And walking is, I do a lot of studies in walking. And actually as part of the Nature RX study, it's a combination of walking in nature while doing a meditation. So it's a combination of both physical and mental health. So walking is a major part of my study, and I can talk at length about this. But
I
yeah,
can
so
tell you from walking, I do a lot of meditating.
that's good. That's good.
Because what else are you going to do when you're walking?
That's true. That's true.
Thank you for that question. Anyone else?
Thank you, Dr. Hahn. So, something that's so difficult about doing health or medical research as someone in the discipline of planning or in a sort of disconnected discipline, perhaps, is that it's very difficult research-wise to connect features of the built environment or interventions in the built environment or in the transportation system directly to health outcomes, which is why I think your study using sort of the personal medical records as the middle was totally worthwhile, and I've read it. It's an excellent study, but that's very hard to do in the United States because we don't have centralized insurance, and it's very difficult to access medical records. How do you suggest, sort of conducting research in a way that directly links a built environment or transportation intervention to a health outcome, and not a healthcare outcome necessarily, which is often the way that I and other people do it, right? If you have a transportation service, perhaps you miss fewer medical appointments. That has a healthcare implication, but it's very hard to establish a health implication. So if you could talk a little bit about that, I would love to hear.
Yeah, excellent question. That's the challenge that I go through in many instances. And actually, the data is there. I mean, you can link personal health records with all these built environment data, but it's really hard to get. And that's probably the most, the challenge that we're having. But for example, the study that I've done in Canada, we weren't allowed to bring the data out. So we actually had to create a fake ID to be employed as part of the healthcare institutions and being employed as a GIS analyst for a hard time to make that linkage. So it's really that difficult. But to answer your question, so basically making a direct connection between the built environment and health maybe it's really hard. But if you think about the pathway from built environment to health, there are many different stages, many different mediators. So for example, if you think about diabetes, we can actually measure physical activity. And that would get in the way, will link the connection between the built environment and health. So not only just talking about the long-term health impact, but we can actually measure the short-term health and behavior impact. So that's something that we can do as people in the social environment or in a built environment disciplines. But I agree, and getting the actual health record data is really challenging. But it's if we can actually create a map that will link the built environment all the way to the actual health outcomes, the clinical endpoints, we can actually convince the doctors that, well, maybe we can change certain things in the environment that will trigger changes in the short term, the health outcomes. And let's do this study to look at the long-term health impacts. So I think it needs a little bit more convincing, and we need to have doctors involved as part of the study. But let's think about the short-term outcome first, and that has been my strategy.
Thank you for that question. Anyone else? I did want to ask Dr. Hung, earlier today at lunch, we had an engaging conversation with you about the difference between the shiny new technology and more simple technologies that often go a long way. You touched on it briefly in this presentation when talking about most falls happening in a bathroom. Could you talk a little bit about just like the broader concept, the broader idea of simpler technologies perhaps being a better avenue to have healthier cities, healthier environments, as opposed to the more techy, shiny technologies that often get more of the headlines?
Yeah, that's a million-dollar question, because we can't ignore the fact that people gravitate more towards shiny new things like AI. We see the AI is going to revolutionize our society and whatnot, and there's billions of dollars at stake. Of course, we cannot ignore that because that's a human nature. But I think we need to pay attention to these actual problems, like not just the technology, not just the means, but what's the actual problem? And that's why I'm doing a little more qualitative study to actually listen to older people and what their problem is in their house. And sometimes the technology can be just a simple technology, providing there with handrails, giving them canes, giving them walkers. Not a fancy robotic technology, but just a simple technology can actually make their lives much easier. And it has a lot higher adoption level than giving them robots to play with. So maybe the way to utilize the shiny new things is to really humanize those technology in ways that we can increase adoption level from older person's perspectives. So I like the term silent technology rather than shiny new technology, silent technology that's embedded in all our lives. So I don't know if that answers your question, yes, but I think the appropriate technology, silent technology, is the way to go.
I have one more question if nobody else does. And this is a question more so to provide our audience here today with broader context about the term aging population, because I know I've been guilty of this in the past. You think of an aging demographic as just being all the same, whether they're in their 70s or whether they're in their 90s. Could you talk a little bit about the broader context of how you think about the aging population and a more nuanced understanding that you could provide to us about that?
Yeah, thank you for bringing that up. So when we talk about older adults, the traditional definition of older adults is 65 plus. And if you think about human lifespan as close to 100, we have a huge spectrum of older adults between 65 and 100 years old. So maybe 70-year-old may be drastically different from people in their 90s. So in gerontology, people try to categorize age groups in terms of young, old, middle, old. Just like we're categorizing teenage and younger populations. So we need to think about these diversities in our aging population, not just clumping older adults in just one category. There is a wide spectrum, and being able to identify what are the constraints and challenges related to those particular groups of older adults. So I think we need to think beyond just older age as just one group, but being able to diversify our understanding of those.
Thank you for that answer. And one last call for any questions. Yes.
First, I would like to thank you again for your presentation, Dr. Hank. That was really insightful at many levels. As someone that has been working with populations struggling with developmental, cognitive, developmental, so I feel like what you've been sharing was really insightful when it's come to the way to approach our environment, particularly when it's come to in-built environment. For example, I was working with some individuals that will be having difficulty sometimes to deal with basic daily activities, from elders to adulthood, and even individuals that we consider as young adults. What I notice is that because of the difficulties that they were encountering, sometimes we had to work on the environment. So we had to work of environment engineering, as they called, if I can say in this field particularly. We had to make sure that if they couldn't make something particularly, we have to change the environment for them to be able to make it. Now, this is an approach that I really appreciate it, but to narrow down the scope to the US or Canada, it's something pretty helpful. But from someone that is coming from another environment, I feel like possibilities are a bit limited because these type of discussions are not often part of our spectrums. What will you propose to be able to diversify this conversation, to be able to, if I can say, open up a broader horizons for them? I don't know if it makes sense as a question.
Sort of. So let me see if I got your question right. So basically, the question is about maybe the more urbanized places or more places that have higher income status. It's easier to change things because it's more modular, it's systematic, and there's a way that we can approach and fix things. But in low-income countries, the developing countries, things are not as organized. So, and a lot of people, maybe they're living in informal housing situations where it's really difficult to address any of these challenges at home, outside, and anywhere. So I guess your question is about how do we actually conceptualize and how we tackle these differences in our urban environment, the high-income countries versus low-income countries where things are less organized. Is that the question?
I like the way you propose the perspective. Well, I will not actually talk about like low-income countries, but I would say a difference of mindset. So it's not really related to the economics, but mostly about the way people perceive things around. Like I've been liking, for example, one example that you provide in your presentation about this person living in Atlanta and talking about disability, being legally blind, I think they said. And because of like the structure of the sidewalk, they really had to be aware of the environment most of the time because 1 inch could make them fall maybe. See, so it's not really about the income here, but the environment that shape in a way that you have to be aware most of the time. And in a population that do not bring this type of topics in general because of their perspective, what can we do to provide, if I can say a broader perspective, to make them think of it?
Yeah, so a very, very good question. So in gerontology, in geriatrics research, there's a framework called person-environment fit. So it's not just about the environment, but people may perceive their environment differently depending on the different stages of their lives, their perspectives, and their cognitive functioning and disability levels. So they're really focusing on not only just understanding the built environment, the external factors, but also being able to understand the internal capacity of patients. So that's where this person-focused approach, but also the place-based approach can meet together to be able to understand what's the best person-environment fit for that particular person. Of course, it's easier said than being done because we have to understand the individual circumstances, but that's probably the only way that we can actually tackle some of these problems from their own perspectives. So that's why I'm grabbing more towards the qualitative research and thinking about how we can scale this qualitative research in ways that we can create huge impact. So I don't know if that answers your questions, but yeah, I mean, the frameworks are there. We just need to be able to refine it and use it.
Okay, so thank you so much for coming today. I think we have a lot of interesting information that we can use in different discipline. So you've been mentioning a hot topic, which is obesity, and I think that most of the time it's also related to the access to nutritional food, right? So I was thinking, what role does the access to healthy food option, or I guess how should we plan as urban designer to create this accessibility to this particular population, to everybody actually, right? How should we think? Should we think about zoning regulation? Should we think about education maybe? How should we convince all those stakeholders to think about this particular aspect? And
So,
that's a pretty open question.
Right,
So.
that's $1 million question. So we tried hard. We know some of you may know the term called food desert, right? We're actually retiring from that concept because the food desert, it's not really a desert, but it actually it's more about accessibility issues. It's not just the physical distance, but maybe there's a financial constraints. So even if you put a Whole Foods right next to your house, you may not actually use it because of these financial barriers. So we've been thinking about this accessibility problem only from a distance point of view, and we create this term called food desert. But people are realizing that the problems are beyond just distance. So we need to be thinking about financial constraints. Of course, we need to think about proximity if there's no place to get fresh food. But thinking about cultural issues, thinking about financial issues, thinking about physical accessibility issues, all things together, we need to do a more comprehensive understanding of accessibility from the person's point of view. So that's $1 million question, and people are struggling to find the right strategy for that. So, yeah, we're sort of going beyond the distance. So, I mean, I don't think there's a silver bullet. I don't think there's a definitive answer. We tried that and we failed miserably. So, you know, some governments, they put more tax incentives to increase access to supermarkets. And the research after research are saying that it doesn't work because of all these issues that we're facing, especially with the financial incentives, financial constraints. So maybe best way to sort of think about from a policy perspective is really think about these financial barriers as part of the accessibility issue. It's not just the access to destinations, but it's accessibility in terms of their financial means. So focusing on those, I think, and combine that with proximity issue, I think is the good way to start.
Any last questions before we end today? Well, thank you all for being here. Thank you, Dr. Hong, once again for being here and providing some insightful information and presentation for us. Hello to my students. Thank you all for making the effort to come out here and for listening to this talk. With that, I guess we officially close, and thank you, Dr. Hong, once again for all of your time and generosity of being here.